Good afternoon. Welcome to the first in a series of webinars on science, policy, and hope, which is part of our COVID-19 virtual series. I'm Michael Whitfield, Chair of the Department of Biomedical Data Science at the Geisel School of Medicine, and I'm really honored to be moderating today's program, which is titled Health Disparities Can Help. Before I introduce today's speaker, I want to run through a couple of housekeeping items. First, please submit your questions through the Q&A button, which is located at the bottom of the webinar window. We will do our best to get to as many questions as we can during the next hour. Please reserve the chat box for any technical challenges you might experience. And the webinar is being recorded and will be made available to all attendees after today's session via the Geisel School of Medicine YouTube channel. In addition, CME credits are available for today's event. And if you would like to receive CME credits, please email geisel.alumni.relations@dartmouth.edu. You should also be able to find this address in the chat, and we'll follow up with you after the webinar. You will be receiving a survey at the conclusion of today's program. So please take a brief moment to provide your feedback to help us enhance future programming. So with those housekeeping items taken care of, it's my pleasure to introduce to you Dr. Irene Dankwa-Mullan, who received her medical degree from Dartmouth in 1997. And she is served as Deputy Chief Health Officer and Chief Health Officer, or is serving as Deputy Chief Health Officer and Chief Health Equity Officer at IBM Corporation and IBM Watson Health. Prior to joining IBM, Dr. Dankwa-Mullan served in 2 roles at the National Institutes of Health as Director of the Office of Innovation and Program Coordination and Deputy Director for the Division of Scientific Programs within the National Institute on Minority Health and Health Disparities. Dr. Dankwa-Mullan currently serves on the Board of Advisors for the Geisel School of Medicine. So with that, please welcome Dr. Dankwa-Mullan, and we look forward to seeing your presentation.
Thank you very much. Thank you, Mike, for the very kind introduction and for inviting me to participate in this webinar series and highlight this very profoundly important topic on health disparities, COVID-19, and how data science can help. It's so wonderful to be here with you virtually. And I'm really honored to be speaking today. The COVID-19 pandemic has deeply affected us all, and many of us have lost colleagues, friends, and loved ones. And our hearts are profoundly saddened each time another life is lost to the disease. So I want to make sure that we acknowledge how much pain and suffering is occurring around the world, and especially the hundreds of thousands of healthcare workers across the globe who are facing extraordinary challenges in fighting the disease. And I also want to acknowledge the hardships of all those who have been hard hit, faced with unemployment and relying on food banks or even fear of losing their homes and livelihoods. And so I know that these times have brought on extremely stressful situations, and particularly for disparity populations. And so I want to express such deepest appreciation, everyone working together to research or teaching, volunteering, finding new ways to deal with the crisis. So with this in mind, I would like to outline my presentation for this talk. I'm going to begin with an overview of IBM's efforts to address COVID-19 using big data, computing power, technology, and analytics. And I also want to share some emerging data or reports on the alarming cases and fatalities that's by COVID-19 and finally discuss how data can help, or data science can help to address some of these complicated questions that we're facing with COVID-19. And as we get deeper into the pandemic, we're beginning to unravel the many complicated issues around testing, transmission, infection, even immunity, timeline to recovery, when to open up businesses. So we always find ourselves asking, what are the important issues and what data science will allow us to understand and intervene more effectively. So what's IBM Watson Health? We're an organization. We're part of the IBM International Business Machine Industry, which is a 108-year-old company, and helping to lead the transformation of health around the world by applying next-generation technologies such as data, analytics, artificial intelligence, the hybrid cloud, to really address the most pressing health challenges. We're headquartered in Armonk, New York, with operations in over 170 countries. At least 70% of all IBMers are based outside of the US, with the largest number in India, actually. And many of you do not know that IBM employees have been awarded 5 Nobel Prizes and 10 National Medal of Technology and National Medals of Science awards. So in terms of how we are responding to COVID-19, IBM is currently addressing the global pandemic using a 3-pronged framework of leveraging technology for accelerated discovery, being a source of trusted information, and really supporting that resiliency and adaptation. And so what we're trying to do is marshaling all our resources to be able to tackle the pandemic on all fronts, leveraging our skills and expertise. In terms of accelerated discovery, we've partnered with the White House, the US Department of Energy, to offer the use of supercomputers to study the pandemic. So what this does is actually allow us to perform virtual experiments that would have taken us months in traditional computers, let alone years if we're doing them experimentally, and compress them to a matter of days or even hours. So with supercomputing, we're able to run very large numbers of calculations in epidemiology, in bioinformatics, and molecular modeling. And they allow researchers to develop predictive models and analyze how the disease is progressing, as well as to help model new potential therapies for a possible vaccine. So for example, there was a study in which they identified 8,000 molecular compounds to see which appropriate targets were relevant to COVID-19. And it was in a matter of days, they identified 77 that looked most promising. And this international consortium, which had more than 30 researchers, finally settled on 7 potential viral proteins to screen for drug-like molecules against certain parts of SARS-CoV-2, and they believed that had like vulnerabilities that the drug could exploit. So this is some of the ways. And so we realize a great sense of urgency. Time is of the essence to bring the science to the implementation front. We've also tried to process all we actually have processed all newly sequenced public SARS-CoV-2 genomes, yielding over 2 million sequences, including the genome, the genes, the protein. And what we want to do is actually by describing the collective biological activity of a virus, we can accelerate development of target drugs and vaccines and inform health interventions. And so we're offering this IBM functional genomics platform to support important research to identify molecular targets to health during the pandemic. In terms of trusted information, we certainly know that those at the front lines need trusted evidence-based information at the point of care to support decisions related to COVID-19. So in addition to the quick access to trusted information for risk assessment, containment, mitigation, this is so much more important more than ever now because of the influx that patients and the economy is putting on the system, sort of the pressure on the system. And in this slide, you actually see the 6 phases of a preparedness, response, and recovery framework for pandemics, which has been updated by the CDC. These phases include investigation of the case, early recognition, so that we can increase potential for to mitigate the pandemic. We can initiate. So there's also the acceleration, initiation, acceleration, deceleration, and preparation. So what we're doing in this front is we're actually supporting several hospitals, health systems, governments around their business continuity, around supply chain, work and learning from home, basically addressing COVID-19 research, clinical and population health needs. So I do want to use the next session of my talk to highlight health equity and the opportunity we have now more than ever to address the inequalities that have unfortunately surfaced from the COVID-19 epidemic. And I'll begin by explaining, or I want to examine some of the language that is used to discuss health disparities to come to a common understanding of the ways different terms are used. You may hear disparities, inequalities, inequities, or variation. And for the most part, they are linked along the dimension of age, disparities, gender disparities, race and ethnic disparities. And when we talk about health disparities, we are referring to a particular type of health difference that is closely linked with social, economic, or environmental disadvantage. The picture on the left screen helps to illustrate the difference between equality and equity and inclusion. These are 3 uniquely different individuals that seem to be watching a baseball game. In the first image, it's assumed that all 3 will benefit from the same support, and so they're being treated equally. In the second image, individuals are given 3 different supports to make it possible for them to have equal access to the game, and we call them that, they're being treated equitably. However, in the third image, all 3 can see the game without any supports or accommodations because the cause of the inequity was addressed. The systemic barrier has been removed. So when I talk about health disparities, we're actually referring to that difference in outcomes, difference in exposure, because health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their race or ethnic group, based on socioeconomic status, mental status, cognitive, so there's a whole list, or other characteristics linked to discrimination or exclusion. Health disparities have existed for long in the United States and even around the world. They're very long-standing. They've tracked particularly along racial lines as well as socioeconomic status. For example, the life expectancy of Blacks in the United States has always been shorter than that of whites or even the general US population. We also know that American Indians, Alaska Native, also experience a high burden of mortality and other disparities compared to the general population. And so the COVID-19 pandemic is already disproportionately affecting racial and ethnic low-income populations, similar to the 1918 and 2009 influenza pandemics. Data from these previous pandemics demonstrate that disparities in exposure, susceptibility, access to treatment also led to poorer outcomes, hospitalizations, and death. And so with this COVID-19, preliminary data and reports reveal that members of socially disadvantaged or deprived communities globally are disproportionately more likely to get COVID-19 infection, experience more severe disease, have higher death to population ratios from the disease. And so with this epidemic, as many cities and jurisdictions, and eventually New York City presented when they all presented their COVID-19 data on testing rates, mortality rates, hospitalization, and death rates, we began to see this huge disparity that was significant. These race disparities, that is the proportion of case and death ratios to the totality in their populations, were 2- or 3-fold among Blacks, Asians, and Latinos than it was among whites. This is showing a CDC report that included race and ethnicity data. This was initial data from 580 patients hospitalized with laboratory confirmed COVID-19. They found out that 45% of individuals from whom race or ethnicity data was available, right? Because not all were. 45% were white compared to 55% of individuals in the surrounding community. However, 33% of the hospitalized patients were Black compared to 18% in the community, and 8% were Hispanic compared to 14% of the totality in the community. So the data clearly, as you tease out the hospitalization and severity of COVID-19, suggest an overrepresentation of Blacks. So, disparities in testing and hospitalizations and severe disease are indeed global. And preliminary data and published reports, even from the UK, from Brazil, among others, also reveal that members of socially disadvantaged or deprived communities are more disproportionately likely to get infection, to experience more severe disease from COVID-19. And you can see the world map on the right-hand side of the screen shows the total confirmed COVID-19 deaths per million of people as of yesterday. And, because of limited testing and challenges to attributing cause of death to the number of, confirmed deaths, this may be even an underestimation. When you look at in the United States, where there is increased access to testing, we see a rapid increase in confirmed cases between February and May 20th. And we should note that this really rapid emergence of cases suggests something more structural, a structural determinant or a socioeconomic determinant that was driving these disparities, and not just behavioral or lack of social distancing or international travel as was previously thought. This crisis did not just happen in a vacuum. This rapid surge of disparities really happened for several reasons. Coronavirus is actually revealing, our, inequities that exist in the system. racism, structural discrimination of marginalized communities, poor treatment of disenfranchised and immigrant populations. And so the reasons for health disparities to me fall into 4 categories. There are the social determinants of health, which could include, living conditions, transportation, health literacy. There's also workforce, essential workers, and those at the front line of care, being mostly from either racial, ethnic populations, underlying comorbid conditions, as well as differential access to testing, barriers to testing, and timely receipt of care. So communities that have a high proportion of essential workers, many of whom still have to go to work, even if they are concerned that, exposure, about the exposure, still experience this differential risk of transmission, hospitalization. And I would show you this slide, which is in New York City, where COVID-19 positive cases, as we could see, was not only occurring along racial lines or race and ethnicity, but also reveal the impact of residential segregation and how people living in these communities were impacted by the labor market or impact the labor market as well as the housing market. As I mentioned before, these individuals have to go to work in order to pay their bills. And they may be working at your local food, groceries, Walmart. They're the ones, picking up your trash to keep our neighborhoods clean. These are individuals who may also rely on public transportation, live in, densely populated areas, go home to crowded homes, which may be multi-generational, and they may be underinsured as well. And so when you look at the maps of number of positive cases, and also see how this really maps to communities of color, densely populated areas where there's high service workers or rent-burdened households, it reveals that story or the part of the data that we're not seeing, which may be invincible. So how can data, big data, or data science help? This final part of my presentation will, help just illustrate how we can perhaps use data science to really help address disparities. And fortunately, I've never seen such collaboration globally. Healthcare professionals, scientists from all over the world are steadily gathering an enormous amount of information about the virus, the trajectory, the biological activity, risk factors, symptoms, who it's actually getting severe disease. So each and every new piece of information, every chunk of data, tidbit adds to our collective knowledge and brings us a step closer to beating COVID-19, whether by controlling its spread, reducing its impact, developing a vaccine. But health data can be really subject to bias in multiple ways. And the increasing quantity and types of data that are available today sometimes make it hard to identify where bias can emerge. But it's important to talk about it, and it's important to do something about it. The algorithms, the models that we're using with data, or these algorithms that we're developing rely heavily on data. So if data is not complete, or if it's missing, it really impacts the results and can have negative consequences. This table actually shows the different types of bias, and generally, bias in data science has been defined as a systematic error introduced into sampling or testing by selecting or encouraging an outcome or an answer over another. I know, for example, but in computer science, bias is defined in terms of the data set. Bias in labeling, we talk about bias in sample selection, in model structure, favoring certain types of error over the others. But in medical and social science research, bias is defined as any tendency that prevents unprejudiced consideration of a question or advances prejudice in favor of or against one group compared to the other. And so you could see, whereas in computer science, in medical or social science research, they all share an acknowledgement that bias implies error. Even though one may refer to bias in terms of a data set, the latter, social science research, medical research, looks at bias in terms of outcomes. So how can it help? Really, data science can help to identify barriers and challenges to social distancing. So for example, as you saw in the slide, previous slide on New York City, it highlights not just the cases or deaths, but you can actually see the hotspots or stories or actual reasons for the differential death cases or proportion. It will help us identify unique factors, patterns, indicators, and also any social vulnerabilities in the community that can happen during the outbreak. In terms of, I want to conclude now and talk a little bit about that. As of April 20th, I didn't see anything more recent, the WHO, CDC, White House, those specific measures or strategies that have been identified, I selected those that were aligned. And when you read those measures or strategies, they all have implications for addressing gaps in data, addressing testing, access to care, and all social, economic, and disparities resulting from COVID-19. And so, when it talks about COVID-19 transmission being controlled to a level of sporadic cases, it also talks about engaging communities. It talks about identifying outbreaks in high vulnerability settings and minimizing it. And all these strategies to address COVID-19 response, recovery, really requires a concerted and coordinated effort that is informed by health equity lens and integrated into all policies or all practices and scientific evidence. Because we all have to understand that the risk of exposure, the risk of infection, hospitalization, severity is not evenly distributed across all populations, across all regions, and across all communities. So thank you for listening, and I'm happy to take any questions.
Thank you, Dr. Dankwa-Mullan, for that really nice presentation. It's really timely. It's given us a lot to think about, and there's quite a few questions that we already have coming through the Q&A. So just to start, you presented a lot of really nice scientific data here, and how do we ensure that these type of data get to those who are making policy, to our political leaders and others, and influence how these things are addressed?
Yeah, that's a great question, Mark. I think, we all need to do our part, and more than ever, we do need collaboration. And I think I've never seen so much effort from the global community to come together and think about, how to really accelerate discovery and the science around this. It's really important that we publish these reports, we disseminate it to the policymakers, because every bit of this science or information or data has implications, right, for policy, especially with regards to the recovery and the recovery around, and as well as the in the future, and even looking at where, in terms of the next pandemic, coronavirus, we need to be really prepared. So dissemination, reports, being transparent with the data is really key.
Great, thank you. Our next question, which I think builds on this a little bit, is there's a question from one of our audience members asking if there's an association between the advent of politicizing COVID-19 with the observation of adverse outcomes mainly affecting African American and minority populations.
Yeah, I think we should, we are in the midst of a pandemic, and people are suffering. I mean, people are dying, and this is the time that we need to put besides our politics, and get to working together to find out the reasons, and be transparent with what exactly is happening and how COVID-19 is impacting African American communities. This is a chance for us to, like I mentioned, health disparities have existed for long, and especially in African American populations and racial ethnic minorities. And so I would answer that to say it's not, there's a time to politicize this, but it's a time to actually, stop the burden of suffering and that's happening, and look for. I mean, we right now we need to think of our neighbors. We need to think of our next generation, and contribute, to the science around it, and find out how we can really mitigate the pandemic and find a cure or vaccine.
Great, thanks.
Okay. Mm-hmm.
So we have another question from one of our audience members of how much of the disparity in the U.S. can be attributed to differences in testing and reporting standards? And it was noted that the U.S. has approximately 4.25% of the world's population, but is reporting about 30% of the total number of worldwide COVID-19 cases and 25% of the fatalities. So you think that's a difference in testing and reporting standards, or is it something more to do with the temporal progression of the disease, or something else?
I do think testing plays a part. I mean, and I would underscore data or the reporting, right? Because it's what's being reported. It's very possible that we are not seeing the true numbers because of, not enough testing. But it's also but I think that the reason for the rapid surge, between February, as you saw on the map, is not just testing or social distancing behaviors, but it's also because of something structural. Racism and discrimination, where, for example, when the COVID-19 was, we knew that there was community spread, they were still asking about international travel. They were still asking about, have you gotten in, known someone who's been infected? And the question should have been, really testing and figuring out whether they are at risk. So high risk communities, and, that may have been more susceptible to the COVID-19, really were behind the ball because they were not able to get tested. So I think they're all related, but I think largely, due to some structural inequities as well as, us not acting quick enough to, stop the spread. So
and what do you
really,
think?
Really good question.
And what do you think we can do to begin to address those inequities and then begin to address these higher infection rates within minority populations? I mean, what are key actions that we should be considering?
I mean, I think that there's a number of ways in which we can address it. Engaging the communities, and for example, if you know that a community does not have access to or use public transportation, and sites are set up, called mobile, drive-through testing. I mean, then you, in a way, communities that do not have cars are not able to go through drive-through testing. So I think it could be tailored to communities, but I think more than ever, we all need to come together and have a health equity lens, think about the importance of education, especially around, the science we know about disparities, and especially, helping to channel resources, because sometimes it's a lack of resource allocation in these communities. It's lack of awareness. One of the things I want to say, even sometimes I say, is that, all the wonderful or innovative things that we are experiencing now that we take for granted are really knowledge and ideas that came up in the 1990s and the 2000s. And it's the foundational substrate that we're exploiting today. And so if we now understand the influences of the social determinants of health on disease mechanisms, we really need to ask ourselves, what are we contributing to the science that we know now, to that legacy? And sometimes when I think about it, I get a bit worried because there may be some who have the attitude that whatever happens, happens. But, and I'm sometimes skeptical that we're not doing very much of anything. But to me, our identity may be at risk if we actually don't care about these challenges or inequities or the science that we know around disparities. Because those brilliant discoveries or science advances are shadowed. We need to, really capitalize on that and build on the science. And it's really necessary to talk about that and make the world a better place with the science we know.
Yep, I agree. So at one point in one of your slides earlier, you talked about acceleration, deceleration of disease analyses that have been done. Can you comment on whether or not you believe the US is in a stage of deceleration, or is that data still unclear?
I think in the US, different regions will have different maps, right? And so there may be some parts of the US that will be, right now, we're past the preparedness stage. So there was a preparedness, response, deceleration. And there may be some communities that enacted policies in place, and stay at home, and they were very strict with social distancing and with testing. And they may be on the downward curve or a little bit of flattening. So it's very region specific, state and even county specific. And I think we should see what happens with now partial, shutdowns where some states are opening. We should know that, transmission or infection happens 2 weeks after, so we may not be able to see any spikes until a couple of weeks down. It doesn't mean that once they open, you see cases surge right away because there's sort of a lag. And so that will tell us a lot about whether these social distancing or partial shutdowns, opening up the economies are really helping with the deceleration process of flattening the curve.
So it really has to be considered regionally and within geographic
Correct.
locations. Yeah.
Absolutely.
And
yeah.
So we have another question from our audience asking for those who have experience in data science, in statistics, what groups are doing good work in your view and addressing unequal outcomes with data, and how might other individuals get involved in these types of analyses?
That's a great question. A number of organizations, including industry, academic, academic institutions that are all looking. I know, Johns Hopkins and CDC and WHO are tracking. So there's publicly available data right now and a huge data source to tap into. It all depends on the research questions you're asking and how you are using the data. A number of sites that are actually using it to track county level or regional determinants. I think that's good because you want to really explore determinants of the disparities or help address some of the back to work or economic recovery. I think you need all of that in addition to public health infrastructure or primary care, because every region is different. They have different populations. But in terms of getting involved, I think there's so many ways to get involved by working with your local community health department or finding out ways in which you can collaborate with different scientists. I mean, right now there's a lot of transparency and openness and opportunities actually for collaboration. And we at IBM Watson Health is always looking to collaborate as well.
Great, thank you. So can we also, well, I'd like your opinion on how dependent is this collaboration across the US, but also global collaboration as we start to look across other countries, dependent on international organizations like the World Health Organization?
Very, how dependent are we on the World Health Organization? So I would say the World Health Organization is playing a key role in this global pandemic. For one, they are putting together, they usually will pull together a global strategy or measures that countries can build on and tailor to their specific needs. And so they also have a lot of, that's where all the data and reports, they've been able to assemble a huge database of data that if you're interested, anyone interested in data science or looking can take advantage or use it. But they are pulling together a lot of guidance and reports and documents that can be very valuable for countries to partake. I mean, we should realize more than ever with COVID-19 that we are a global community, and we are all sort of a brother's keeper. And so what we do for ourselves, we need to also consider for our neighbors. If our neighbors are not safe, we may not necessarily feel safe.
So who is maintaining a lot of data repositories for international data
yes.
on this? And is that accessible to, the average data scientist that might want to get involved, or does it have to go through certain protocols to access it and so on?
I believe it's available. They have a huge COVID-19 repository of all the published evidence, all the reports. You just may need to make sure that you validate and I think that's what they do before they put it in the database. CDC is also feeding information from the WHO. So there are various sites that validate the information.
So we have another question.
It's publicly available.
It's publicly available. That's great.
I think yes, it is publicly available.
Great. So we have another question about data and data consistency, but within the U.S. And our audience member has asked or has stated that there seems to be a lack of consistency in terms of COVID-19 data reporting from state to state and also country to country. And so as an example, attribution of mortality to COVID-19 versus comorbidities. So how do you think this is being or should be addressed?
Yeah, so that's a huge issue or problem that there are a lot of inconsistencies. There are gaps in the data. One state may be reporting all the race ethnicity data or cases, but others may not necessarily be reporting. And for the most part, the data may also be lagging. I know that there's been pressure on the CDC as well as on states to actually work harder to make the data more complete and accessible. And so I'm hopeful that this will happen where the data will become a little bit more complete and standardized at least, so that we can use it to inform science and inform our health interventions or implementation efforts. But that has been a huge issue. Data is always there's always a lot of completeness or missingness, and I think more than ever this is a time where we need to think about if we are really going to understand or address the complex issues around COVID-19, then, like I said, every tidbit of data is essential. And there's nothing, we should not make some visible and some invisible. So this is more important, that we need to really work to continue to expose what data we have and work on it, and because it's for the benefit of everyone.
Yeah, no, I agree. And I think it's a really important problem, and hopefully this can be addressed as time goes on.
Yeah.
So next question from one of our audience members. Any information or predictions about how successful contact tracing will be in the US? Do we have big data that really addresses this point?
Yeah, I would say I have not really studied much on contact tracing, but I do understand that countries in which there is comprehensive and extensive contact tracing are doing much better in terms of controlling the disease and controlling transmission. So there is evidence out there, the need for contact tracing to really do the case isolation and quarantine. And this is something that we've been discussing within public health, that this would be, a new transformation of our public health system, where now more than ever, we need to think about our workforce, and especially in capacity, right, within our states, within our region. How much people who are engaged in contact tracing will be needed, because it's not just going in and talking to an individual and asking, or telling them they've been exposed. I mean, it's a special skill that's required. So I think there's going to be sort of a shift in our public health workforce. But it's definitely, to answer your question, very much needed in regions in which have comprehensive contact tracing have done better in terms of controlling the transmission.
Mm-hmm. So if I could ask a question, has IBM Watson Health considered using various network-based methods to consider contact tracing in terms of I don't know, the ways to look at individuals that someone may have contacted in a data-driven manner?
There are lots of there are a number of initiatives that are going on at IBM Watson Health, and I would look into whether this particular initiative is being done. Definitely as part of our work to, there's a lot of collaboration going on, and this may be one of the initiatives that's sort of under consideration. So I will check on that, and that's a good question.
Okay. So another question from one of our audience members. So this question says, you mentioned similar disparities from the 1918 and 2009 influenza outbreaks. Have researchers also seen these disparities from the 2003 SARS outbreak? And it goes on to ask if there are also factors that disproportionately affect certain racial ethnic groups based on this type of virus. So maybe underlying health conditions or anything like that.
Yeah, that's a good question. I have not seen any scientific evidence or report with robust analysis around the SARS in terms of disparities. There may have been reports around, along sort of socioeconomic status, but this is a good question, and it's something that I'm definitely going to find out since they are, there are some similarities with that.
Okay, great, thanks. So going back to the question about the World Health Organization, we have one of our audience members has noted that, of course, U.S. has threatened to permanently halt funding to World Health Organization, and will that be a problem for global cooperation? And do you maybe a thought on how that might impact global cooperation? I know we got into a little bit in the prior question that we talked about.
Yes, and I would say that I am afraid it will. I'm just sad that this might happen, or it's going to happen, because this is a time where we all need to come together and work on the science and work together on policy, and so and the World Health Organization is doing a great job in terms of helping to marshal resources or help with advancing this global collaboration. So I just feel a little saddened if this is going to happen, and I think yes, it might. Science, in terms of scientists and researchers, we always work across. We collaborate globally, and I think that will still go on. But I'm just afraid about our individual, our U.S. identity, in the global world, pulling out and the implications it has for our technology and science advances.
So to move on to maybe another topic, and one of our audience members has asked that given the shortages in PPE, healthcare resources, and other things that are occurring in many areas, how might data play a role in equitable distribution of these limited resources, either globally or within the U.S., right? Can we find a way to target these limited resources to the most impacted areas?
Yes, that's one of the things that data can do, and especially around the, when there's data tracking, you could do it. And let's see, what I was trying to talk about was more on and I'm blanking out on that, but in terms of in countries where if we know if we know where sort of PPEs and which countries have more of I think it sort of helps. There is, and I'm just blanking out on the on what we're doing, but basically it could definitely help where you can get resources to where there are shortages of PPEs, and there are some institutions or organizations that are engaged in that, but I think more global, states-wise, we can do it. For example, there were some studies that were showing, for example, the shortage of mechanical ventilators, and it's sort of the same thing, where you can actually map which regions have, hospitals with ICUs and which don't, and how sometimes you can, shift resources or send resources to certain places. It did really, I think it happened in the European nations where, there was some help, and I know, even there was, we have countries like South Korea that were, working to make more PPEs and send to different countries. But a coordinated effort, right, is definitely what is needed, and data can certainly help with that.
Great. So we're running out of time. We're getting to the end of the webinar, and I think that we are do not have time for any more questions. So thank you for all those who asked them. I apologize we've not been able to get to all the questions. But I asked, so Dr. Dankwa-Mullan, I wanted to ask if you have any brief closing thoughts you want to share with all of us before we end the session.
Yeah, I mean, I would just close by saying that, as the Dartmouth community or even globally around, I think our mission, should be to make, the world a better place, if not for us, for our generation. And if anything, this COVID pandemic has made us all realize that we are our brother's keeper, and that, we need to learn from each other and leverage all our resources and skills to address what's going on now in terms of the suffering and degradation and marginalization of disadvantaged groups. And we need to talk about being more hopeful and more committed and dedicated to addressing the challenges of living in a complex world. So thank you.
Thank you. Thank you for those closing thoughts. I think that this has been extremely relevant, extremely important, and very timely. So I thank you for taking the time to share your science and your views with the community. So thank you for sharing those insights with us. Thank all of you for joining us today. I'm sorry we weren't able to get to everyone's questions. So finally, please complete the 2-minute survey that you'll be receiving at the conclusion of today's program. Your feedback will help us enhance future programming, and have a wonderful rest of your day. Be safe and be well.
Thank you.